All right, well, I appreciate the opportunity to be here. I have case 6 in this series, no relevant disclosures. So my case is a 62-year-old man with dyspnea, recent onset of heart failure and worsening anemia, diagnosed elsewhere, and has an extensive cardiac surgical history. So 37 years previously, had endocarditis, had a St. Jude aortic and mitral replacement, had recurrent endocarditis about 11 years previously. That was complicated by aortic pseudoaneurysm, had an aortic valve homograft and mitral bioprosthetic replacement at that point. And it sounds like a rocky course, had intraoperative stroke, prolonged intubation and tracheostomy. So not long after that operation, represented with severe symptomatic tricuspid regurg, and then ultimately had tricuspid valve replacement, and I think at that point was, based on the outside records, was also noted to have mitral periprosthetic regurgitation that was repaired. So three prior sternotomies, and past medical history as well. So COPD on continuous oxygen, stage 3 chronic kidney disease, and had a pacemaker for what was described as sick sinus syndrome. So referred to Mayo, his exam here, he is slightly hypotensive, 1, heart rate 78. You can see the jugular venous pressure was severely elevated with prominent V waves. He had a number of murmurs that you see there. So what was described was a grade 3 holosystolic murmur at the apex, an additional grade 2 diastolic murmur at the apex, and then a separate grade 2 systolic ejection murmur at the left sternal border. And then from a volume standpoint, it was felt to be fairly well compensated, just trace pedal edema. So he was recultured on referral. Blood cultures were negative. His hemoglobin was kind of stably low or to slightly downtrending with a hemoglobin of 8.1. LDH was elevated at 350, and the haptoglobin was less than 14, suggesting an element of hemolysis contributing to his anemia. So I'll let you kind of review the echo. So we kind of skip straight to the TE here. So again, for the sonographers or those who don't do as much TEE, again, these are mid-esophageal views. So closest to the probe is the left atrium. This would be the bioprosthetic mitral valve. We have 2 different angles here, a 0-degree view and a 48-degree view. Here's some of the spectral Doppler. This is a pulmonary vein flow, again looking at pulmonary vein flow in diastole and systole. And then this is the transmitral gradient. So at a heart rate of 79, it looks like we measured a gradient of 8. And take a look at the profile there. So based on that, again, I'll show you maybe those images one more time. I'm going to ask you, what is kind of in your view, the primary pathology of this mitral prosthesis? Certainly mixed, but are you more worried about stenosis or regurgitation? So how would you describe the mitral bioprosthetic function? I would say A is a severe bioprosthetic valve stenosis with a gradient of 8. B, moderate severe prosthetic regurgitation, mild periprosthetic, moderate severe periprosthetic, and only mild prosthetic, or more than one of the above. Good. So a lot of you got the right answer. So just to review, I think this is becoming, increasingly important in the transcatheter arena, where we sort of serve as the eyes, really, for our interventionalists. But again, sort of know what you need to see. So this is the bioprosthetic valve here, right? This is bioprosthetic mitral valve. You see sewing ring, and then you see one of the struts here and probably partially one of the struts here. You see the leaflets are thickened and calcified, probably mildly calcified, but they do open reasonably well. To us, the prominent piece of the pathology was all of this regurgitation. So I showed you 2 different views. In the 0-degree view, would be a lateral jet. Again, it's outside of the sewing ring, so this is a big periprosthetic jet. If we switch over to this 48-degree view, Our landmarks are the left atrial appendage, we see the atrial septum, and this is clearly a second medial jet of perivalvular regurgitation. So it's 2 jets of perivalvular regurgitation, probably at least moderately severe, and then probably a less significant transprosthetic regurgitation. And again, that is sort of confirmed in the spectral Doppler, right? So we have kind of these low-grade reversals in one of the pulmonary veins, and we have a high gradient across the valve, relatively high gradient, but it's a very high peak E wave, and then a rapid drop-off. So half time. So a lot of this gradient could be driven as much by regurgitation as stenosis. So everything pointing towards significant regurgitation. So, but clearly, I say it is mixed, right? So the leaflets are thickened. There is some reduced opening, but then you see all of this regurgitation in the 3D, right? So it all sort of just blends together. There's this sort of eccentric transvalvular. This would be the posterior, kind of a posterolateral periprosthetic, and then a smaller medial periprosthetic that we saw on the 2D images. So left ventricular function, this is a transgastric view just showing kind of probably mild left ventricular dysfunction with inferior and infralateral regionals. And here's a look at the tricuspid. So again, tricuspid is also about 10 years old. And we see, again, strut here. You don't see the strut as well on this side. Are thickened, but they do open, and you see just tremendous color flow, right? So color flow filling most of the black space behind the valve, and then a significant flow acceleration on the ventricular side, consistent with significant tricuspid regurgitation as well. So what's the next best step? So again, we have significant mitral prosthetic and periprosthetic regurgitation, significant tricuspid regurgitation, that's transprosthetic. So what's the next best step? Do we redo surgical tricuspid and mitral replacement, transcatheter tricuspid valve replacement, transcatheter mitral replacement, transcatheter mitral perileak closure, or more than one of the above?
The problems with reoperating for 4th or 5th or 6th time have to do with adhesions and exposure of the valves. On the other hand, even though it's a big step to take, it really solves the problems. Now, if you can get the perivalvular leak closed and somehow with a plug and then put a valve in a valve, that might be a way to go, but it seems to me that you're headed towards a redo operation.
And so this particular patient saw one of our experienced surgeons, not Dr. Schaff, but a different experienced surgeon and so we, basically to summarize, recurrent heart failure and hemolytic anemia to multivalve disease, no evidence of recurrent endocarditis. This patient, I mean, the thought was that a redo operation, 4th sternotomy, would be very high risk, if not prohibitive risk. And some of that I hid for the purposes of the presentation. The patient felt to be older than, basically looked older than stated age, and there were some current concerns for frailty, kind of in addition to everything else. And so basically we move forward with a transcatheter approach in this case. So. And essentially all this was done sequentially, and we started with the lateral mitral perivalvular leak closure. You can see, again, similar to that 0-degree view, we see that they've canted periprosthetic leak. Here we just have a wire and a catheter across, and over on the far right, they've actually deployed one of these vascular plugs. So these are probably the most commonly used plug to close these periprosthetic leaks is an AVP2 plug, which is an off-label use of actually a vascular plug. But you can see a really nice result, actually. So very little residual regurgitation at that site. I think what we're seeing here, some of the color flow, is actually that eccentric transvalvular leak. So after they closed the lateral, they've then turned their attention to the medial. And again, here we have a catheter across the medial. And here they may have actually already deployed the plug as well. And we see just kind of trace residual regurgitation at that medial leak. This is a left atrial view, so we often call it the surgeon's view because it's similar to the perspective a surgeon might have if they've incised the left atrium. They're looking down at the mitral valve from the perspective of the left atrium. And here we see the sewing ring from the old mitral prosthetic valve, and then here's that vascular plug. So these vascular plugs have essentially they're kind of a nitinol mesh frame, but on either side they have these two discs. So if we were to see the ventricular side and the atrial side, you have this kind of disc-like structure, and that's actually the plug that's closed that lateral defect. So now we have two plugs in place, right? So we've closed the lateral and the medial with a very nice result, and then they turn their attention to the valve itself. Because remember, the valve itself also had some degree of regurgitation and stenosis. And so this is a 3D image using multiplanar reformatting to show a transcatheter valve that's across the old bioprosthetic valve that's waiting to be deployed. And here's a look at after deployment. So again, we have the transcatheter valve inside of the old sewing ring. We have two plugs with a very nice result. And so, again, looking with 2D and color flow imaging, nice thin leaflets that open well, no significant regurgitation. And remember, there were systolic reversals in the pulmonary veins pre, and now we see this nice kind of codominant pattern in the pulmonary reassurance that this patient's going to feel better. So again, just to kind of hammer that home, this is pre and this is post. So now, again, we're not done, remember, because the patient had clinical and echo features of severe tricuspid regurgitation as well. And so that was a little more simple. There was no periprosthetic leak, and so essentially we deployed another sapien transcatheter valve through the tricuspid, again, with a very nice result and no significant regurgitation. So this patient's doing well at about 1 year post-procedure. It's always gratifying to see the LDH normalized, hemolytic anemia resolved, and prosthetic valve function was normal by TTE. And so just to kind of give you a little bit of the background on this, so there is a sort of growing literature on mitral valve and valve, and this is one of the biggest series that's been published, looking at about 1,500 patients, multi-center, where the majority of these were all transeptal. There were a small minority that was transapical. And if we look at the mean STS predicted risk of mortality in this group is 11.1%, so a sick group of patients. Procedural success was high at about 97% with a relatively low risk of 30-day mortality. And what was interesting in this series, that the 1 year mortality was a little better in transeptal versus transapical. So I think we have increasingly shifted our practice to an all transeptal practice. And in fact, it's hard to remember the last transapical mitral valve and valve that I remember seeing at Mayo. And then, again, similar data for tricuspid valve and valve. So this is probably the biggest series so far, so there's a little less data in tricuspid valve and valve. Most of these in the series were valve and valve. There were a few valve and ring, and sort of intermediate term follow-up up to about 16 average. But the procedural success was high, really low periprocedural risk to the patient. There was about 12% reintervention at 3 years, and this was interestingly primarily related to valve dysfunction, so transcatheter valve dysfunction actually in most of these, and then a few had perivalvular regurgitation or endocarditis. And I think this is my last slide. Again, so periprosthetic leak is something that we've been doing for at least 10 years or more. Dr. Rehal was one who really pioneered this at Mayo and here in the US, but certainly is very effective for high-risk patients with perivalvular regurgitation, improves heart failure symptoms, and reduces hemolysis in those that have it. Again, increasingly, there are transcatheter options for some of these high-risk patients with prosthetic valve dysfunction, and there's a growing body of evidence for valve and valve procedures. I think particularly in the aortic and the mitral, and there's kind of growing evidence in the tricuspid as well. Perivalvular regurgitation is another procedure that can be done in tandem with these procedures to help with perivalvular regurgitation when present. Midterm data on the valve-in-valve prosthetic function appears favorable, but I think what we're lacking a little bit is longer-term data in larger groups of patients. So just something to consider.